Okay, good evening, everyone, and welcome to the 5th session of the online optometry learning series, OOLS. For today's session, we have Professor Bruce. I think he's already online. Most of you have seen him, and we have been talking. So yeah, Professor Bruce, let me introduce Professor Bruce. He's been a faculty member and he's been serving the faculty for about 20 years. And he was appointed as a Marcus Professor of Pediatric Studies as he joined the faculty of the New England College of Optometry in 1997. He has also received the 1998 Best Textbook of the Year award from the American Medical Writer Association for his textbook on eye care for infants and young adults. And this textbook is actually a standard textbook in the pediatric optometry. He is also a fellow of the American Academy of Optometry and a member of the Association for Research in Vision and Ophthalmology. He has over 40 years of clinical experience in seeing children. He's been working at Harvard Medical School and the New England College of Optometry, where he has done a lot of research on children's vision, and he's also involved in the legislation and advocacy for children's vision. We have him here today, and we are all fortunate that he's going to talk to us about the management of refractive error in children. I hope we all have a fruitful and a learning session. Prof, you can take it from here.
Okay, well, thank you very much. I appreciate the opportunity to speak to you today under these trying conditions around the world. This COVID-19 crisis that we're all facing actually is sort of a good point of reference for what I'm going to be talking about. The COVID-19 problem is affecting everyone around the world. The way that each country is managing it may vary a little bit, but it's really important to understand that the biology behind the virus is the same everywhere. The basic reality of the virus is the same everywhere. If we talk about the care of children, specifically the vision care of children, we need to understand that the problems that we face with children in the United States is really different. So I'm going to preface that. And one thing I would like is for everyone to make sure that their microphones are muted so we don't have any interruptions. I'm going to talk really briefly about the process of refraction. And I should say up front, as was already said, my entire career New England College of Optometry in 1975 has been involved in the care of children and children only. Most of my career, I've been involved only with children under the age of 5 or 6 years of age. So it's been a very narrow experience, but it's also been a very deep experience. So I have a lot of ideas about the way we should approach the care of children. This first slide just mentions the process of refraction. I'm not going to go into great detail, but I do want to mention a couple of things that I think are important in comparison to the more general process of refraction with adults and young adults and elderly people and all the rest. And the most important point I want to make is that the techniques that we need to use to find out what's going on with a child's refractive status are largely objective in nature. They are not subjective. And what I mean by that is that we need to see what's going on. We need to evaluate the visual system. We have to make the decisions based upon what we see and what we're able to test. We do not have the luxury, for the most part, of being able to get subjective responses from a child. For example, when we examine somebody, an adult, 20-year-old, a 50-year-old, we ask questions. We're able to get a detailed visual acuity, for example. In a young child, we may not be able to do that. the information we get may be difficult to obtain or may be impossible to obtain. So one of the hallmarks of the examination of a child, not just refraction, but all the elements of it, are that it is an objective examination. The point I want to make is that I recognize that in most countries around the world, outside of the US and Canada and Australia and some of the other countries where optometry has been around for a long time and has gained a lot of additional scope of practice abilities, the ability of doing a cycloplegic refraction in many of the countries where you guys are from may be limited or impossible in many settings. So in the US, for example, we would almost never think of examining a child and not doing both a cycloplegic refraction and a dilated fundus evaluation to determine ocular health. That's a simply basic part of the exam. I recognize that you may not be able to do that, and I'll bring up some of those issues as we go along in the discussion today that I think are important, and you may need to make some modifications to what we do based upon that. So most of what we're going to talk about is managing refractive error, but there's one additional thing I want to touch on, and that was brought up in one of the lectures presented the other day on, I think it was titled Binocular Vision in the Retail Setting. And the lecturer brought up a very, very important test, mentioned it a little bit, but I want to emphasize that. It's called the Bruckner test. And the Bruckner test is an incredibly simple test that one could use to assess very important characteristics of children's vision. The Bruckner test has been around for a long time. It was designed originally by a German ophthalmologist about 150 years ago. And he figured out in a very simple way that this was very useful and very valuable in assessing, in particular, amblyopia. So the Bruckner test takes about 10 seconds to do, and it has the ability of making at least a simple, basic assessment of all three primary types of amblyopia. Now, as was mentioned in the lecture yesterday on amblyopia, there are three primary categories. In terms of natural history, when it starts, deprivation amblyopia happens first. It is caused by media opacity, something blocking the visual access, typically present either at birth or almost immediately thereafter. And if that media opacity is not mitigated in some way, that child's going to develop an incredibly dense, very difficult to treat form of amblyopia called deprivation amblyopia. Fortunately, it's pretty rare. The second type of amblyopia in terms of natural history presentation is often strabismic amblyopia. Strabismic amblyopia happens when there is a constant strabismus. One eye is turned all the time, typically from a very early age. That happens to a greater number of individuals than deprivation, but still accounts for a modest percentage of the total number of amblyopia cases. The final type is refractive amblyopia due to refractive error that may be bilaterally very high, which is called isometropic amblyopia, or it may be unilateral, where there is a greater degree, typically, of hyperopia and or astigmatism in one eye. That is an easier condition to treat than the strabismic, and strabismic is easier to treat than deprivation. Now, how does the Bruckner test allow you to pick that up at different times in a child's life? Well, the procedure is take your direct ophthalmoscope, put about a +1 or +2 in the lens turret, turn the lights down, ask the child to look at a distant object, if possible. If not, just have them look at whatever. You assess the red reflex in both eyes simultaneously. And if there is a difference in the quality or the appearance of the red reflex, that is an indication that there may very well be a problem. So to do that, you simply turn the light on, turn the lights down in the room, have the child look ideally far away as opposed to close up, and look at the red reflex. If it's exactly the same in both eyes, you know that number one, there is no media opacity. If there is, there'd be a dark area. One red reflex may be extinguished completely. If there is strabismus, then one eye is distinctly brighter than the other. And the reason for that is the eye that it's fixing, the better eye, if you will, is looking at the light or looking straight ahead. And the area of the retina that the light from the ophthalmoscope is falling on is an area that is the macula. The macula is darker than the surrounding area. It absorbs light, therefore it appears darker. On the other hand, the eye that is a strabismic eye is using a non-macular position on the retina. The light reflecting off of the retina, therefore, is greater, it appears brighter, and as a result, you see a distinct difference in brightness between the two eyes. Third type, refractive, you'll see a difference in what appears to be the dark or brighter areas within the reflex. The dark area is called the crescent. In hyperopes, the crescent is down. There's a dark area inferiorly. In myopia, there is a dark area superiorly. If there is astigmatism superimposed over the spherical refractive error, then instead of the apex of the reflex being at either 6 o'clock in the case of hyperopia or in the case of myopia at 12 o'clock, it's tilted in one direction or another away from 6 and 12 o'clock. In that case, you can assume that there is some astigmatism in addition to. So in a period of a few seconds, you get an indication of all three types of amblyopia. You may not be able to categorize it that clearly, but you'll see the difference. And if you see a difference, then you know there's a problem. So before I do anything else, while I'm still getting a history from the parent, the child, I'm doing the Bruckner test. I'm doing that. I'm also doing a sweet flashlight test. I am assessing pupils as well because the light source from the ophthalmoscope is bright. You'll get a pupillary constriction, which is made quite visible as you're looking through the optical system of the ophthalmoscope. So I wanted to just touch on the Bruckner because I think it's really important and it's something that people are typically taught and then in my experience around the world, often not actually used by practitioners. Okay, so next thing, let's now talk about managing refractive error. Okay, so managing refractive error. I have a few principles of correcting refractive error that I think really kind of sum up a lot of what you need to be doing and thinking about. So first of all, in order to actually think about prescribing for refractive correction to an individual, whether a child or an adult, you need to consider one of these three things. The refractive correction either needs to improve vision, to improve binocularity, or to improve visual functioning in some way. If you can't justify the provision of refractive correction for one of those three things, then in my view, I will not prescribe. I think you've got to actually be able to justify based upon those three things. The next thing, and this is, I think, about as basic as anything can be in my perception. The basic principle of correcting refractive error is really very, very simple. The purpose of it is put a focused image 360 degrees on both eyes simultaneously. Let me repeat that. A focused image 360 degrees on both eyes simultaneously. Now, I'm going to get into some detail about what I mean by that, but I want to give you an example. And I'll acknowledge that in a child, the concept may be a little bit different than in an adult, particularly for first correction in an adult. So I think the prime example for me is a significant amount of astigmatism. And there are a lot of conflicting views on how to prescribe for moderate to high astigmatism in a first correction for a patient. Many people are taught that if you have a patient with, say, 4 or 5 diopters of astigmatism in each eye, that the first prescription you give should not give that full correction because the patient will have difficulty adapting to it. And that's not an unreasonable perception, because on the face of it, we know that the magnification effects of a spectacle lens that provides that amount of astigmatic correction is very different in the horizontal and vertical meridians, assuming it's with a rule or against a rule of astigmatism. Even worse, I suspect, if it's oblique. So if you have an axis 45 or 135 and you have 4 diopters of astigmatism, many people would say there's no way the patient's going to adapt to that. So instead of giving the full 4 or 5 diopters, let's only give half of that. But what are you doing by doing that to the patient? Well, you're only providing a partial correction. If you're interested in a child in preventing or treating amblyopia, the critical issue is put refractive correction on that child as soon as you can, correct the refractive error so there is no longer optical blur being projected onto the retina. Put that focused image 360 on both eyes simultaneously. So what that translates to is that if you undercorrect the astigmatism, you're still leaving a blurred image on the retina. If you're trying to treat amblyopia or prevent amblyopia, that's not going to work. Let's talk about an isometropia. So if you got a +6 on one eye and a +2 on the other eye, the argument would be, well, the +6, you've got too much magnification, the patient's not going to adapt to it. You've got to cut the difference between the 2 eyes from the 4 diopters that's present to something like 2 diopters to minimize the image size disparity. But the reality is that you're leaving a blurred image on the retina of the eye with a higher refractive error. In other words, you're not properly putting a correct focused image on the retina. You're leaving optical blur. That optical blur is not going to effectively treat the amblyopia and is not going to provide the incentive for the visual system of that individual to be able to put fused images together and provide binocular vision. So to me, this focused image 360, both eyes simultaneously, is the basic element of providing refractive correction. Now, one could argue that in an adult, you might do things differently. And I'm not really going to get into that because it's really outside my area of expertise. But I will say that with children, this is now widely accepted, at least in the US, as being what we do. Now, I'm going to sort of go off on a tangent a little bit here for a second and just really briefly touch on the treatment of amblyopia, because there's something in addition that's really, really important here. And that is as follows. Amblyopia, strabismus, and significant refractive error in children are intimately related. If the child has one of those, in all likelihood, the child can have the others as well. If you have an isometropia, you're going to have amblyopia, and you're going to have probably a microtropia, a strabismus. If you have amblyopia, you're almost certainly going to have one of the amblyogenic risk factors. Amblyogenic risk factors are significant refractive error, strabismus, or media opacity. The definition of amblyopia properly is a diagnosis of inclusion and exclusion. Too often we hear about only one aspect of it or the other aspect of it. In order to have a diagnosis of amblyopia in a child, not only do you need to have asymmetric visual acuity, the old definition insisted upon a 2-line difference. I think most people nowadays would argue that's not real. That might meet a research definition, but it does not meet a clinical definition of amblyopia. In my view, amblyopia is any significant difference in visual acuity that is related to significant refractive error, or strabismus, or immediate opacity. And in addition, there's an exclusion piece of it. The exclusion piece is no eye disease, no structural abnormalities in the visual system beyond the amblyopia and strabismus and refractive error. In other words, no brain tumors. It was brought up the other day in the lecture. The lecturer talked about organic amblyopia. I don't believe that there is organic amblyopia. Organic amblyopia is sometimes defined as caused by methyl alcohol poisoning or an eye disease like toxoplasmosis or something along those lines. That's a disease entity. That's a toxic effect. That is not a functional effect upon visual acuity caused by the inclusion criteria of amblyopia, strabismus, and significant refractive error and media opacity. The first step we now know in the treatment of amblyopia, as brought out by the amblyopia treatment studies carried out by the Pediatric Eye Disease Investigator Group in the US and Canada. People are not familiar with that. Let me just really briefly say that for 100 years, the way amblyopia was treated around the world was unchanged. People either would put a patch on the good eye and on the good eye and leave it on for a long period of time, sometimes all day long, to force the so-called bad eye to get better. Or in Europe, primarily, they would use atropine penalization to blur the good eye. Concept really is the same. You're penalizing the good eye to improve the vision in the poorer eye. Things were not changed. The amount of patching was largely full-time, however that was defined in most countries for probably close to 100 years. The amblyopia treatment studies were initiated around the year 2000 in order to provide an evidence basis to the treatment of amblyopia, to truly understand what was going on and why it was going on. So what those studies did was look at every single aspect of the treatment of amblyopia and provide that evidence basis through good, solid, scientific studies. And what we've now learned in sum total from this about 25 ATS studies that have been published, what we've learned is the single most important treatment for amblyopia is provide refractive correction before you do anything else. So now in most of the world, the evidence basis says very clearly, you got a difference in visual acuity in a child, you have strabismus in a child, the first thing you do is correct a refractive error, which in the case of amblyopia and strabismus is almost always present. There's almost always significant refractive error when there is either amblyopia and or strabismus. Something on the order of about 90 to 95% of individuals with either amblyopia or strabismus have significant refractive error. And that significant refractive error is almost always moderate to high hyperopia and or astigmatism. Maybe one eye, could be both eyes. So the treatment is refractive correction. And what is the refractive correction that has been mandated in all of the ATS studies? Exactly what I've written down here in this slide. A focused image, 360, both eyes simultaneously. Bottom line, that means fully correct the astigmatism at the axis you find. Do not change the difference between two eyes in an individual with an isometropia. If you found a 4-diopter spherical difference, you give a 4-diopter spherical difference. You might decide to decrease both eyes simultaneously. So instead of, say, a 6 on one eye and a 2 on the other, you may give a 4 on one eye and a plano on the other if you so choose. But you don't do asymmetric changes in the spherical component. So I want to make that really clear. If you remember nothing else from this lecture today, please, please, please remember that. And again, This is about children and mostly about young children. Adults, different story. I'm not going to talk about that. Okay. So there are some additional important considerations that you need always to be thinking about when you're providing refractive correction to children. First of all is the process of emmetropization. And just to remind you, emmetropization is the normal, natural, historical change in refractive error that occurs from birth out to sometime during childhood. People argue about when, probably age 5, maybe age 10, sometime like that. We might even think about myopia progression in teenagers as being part of emmetropization, or perhaps more correctly, some breakdown in emmetropization. Typically, babies are born with about 2 to 2.5 diopters of hyperopia in each eye. There is a huge amount of variability at birth. So, in other words, the standard deviation, the spread, if you will, of spherical refractive error in newborns is great. The mean is somewhere around a 2 or a 250. Likewise, the same with astigmatism. There's a lot of astigmatism present, especially between about 6 months and about 2.5 years of age. So there's actually, on average, some increase in the amount of astigmatism immediately after birth, and that may continue until about 2.5 years of age, when it tends to decrease and flatten out considerably. With astigmatism, there can be enormous changes in a period of 3 or 4 months during early childhood. I've seen myself under cycloplegic conditions changes of 3 diopters of astigmatism and 45 degrees of axis in a 3 to 6 month period of time. So this is normal variability. It's something that you can expect will happen, and that actually raises some important questions. Given these refractive changes, especially in early childhood, do you correct for refractive error that you see at 1 or 2 years of age? And I would say that typically you do not, unless there already is evidence of amblyopia or strabismus present. You've got a large angle esotropia, that's quite obvious. By all means, treat it refractively. If you don't, I would argue watch and wait and see what changes occur. Do not interfere. If you put a refractive correction on a 6-month-old that is still undergoing emmetropization, you stand the likelihood of interfering with that normal natural history process of emmetropization, and you may make permanent that refractive error. So you have more potential for messing things up than you do making things better by providing early and inappropriate correction for that. Now, you might consider, when does most of emmetropization kind of sort of stop? And we say 3 to 5 years of age. By 5, most of that hyperopia that's present early on, that's going to go away, has gone away, and no longer is quote unquote significant. Moderate to high degrees of hyperopia that is still present at 3 or 4 years of age, in all likelihood, are not going to go away, because in all likelihood, the process of emmetropization is broken in some way. It's not happening. So the refractive error is going to continue to be present. Can we tell at this point in time who those kids that are going to get better by themselves are different from those that are not going to get better by themselves through natural processes? And the answer is, today we really don't know, but we have a lot of indications that abnormalities in the accommodative system of young children up to 3 or 4 years of age are a key issue. There's a lot of work being done now looking at accommodation in young kids to determine if in fact that's true. But there are pretty good clinical indications that a child that is moderately to highly hyperopic at 2 years of age, that has poor accommodation, is going to stay that way, both in terms of poor accommodation and terms of maintaining that high refractive error. It's not likely to go away. If you have high hyperopia at 3 years of age, you have a normal accommodative system, then it's more likely than not that the problem in the hyperopia is going to reduce over time, and that child is not going to fall victim to an accommodative esotropia that could develop at that point in time. The astigmatism typically becomes set, more or less, by 3 years of age. So what you find by 2.5 to 3 years of age in terms of astigmatism is in all likelihood going to maintain and not change very much until much later on. Now, one may argue about refractive changes, including myopia progression. I'm going to hold off on that until a little bit later on. It's a whole different story, and I'm only going to touch on it. It's a whole different lecture, actually. And my next point is, as I reiterated earlier, the relationship between significant refractive error, strabismus, and amblyopia. There's also obviously a relationship between refractive correction and visual function. So putting a pair of glasses on a kid with significant hyperopia at a young age is going to change visual function in a whole lot of different ways. And that was brought out, I think, very nicely in that talk about amblyopia the other day. There's a whole lot of relationship between visual function. Visual function is something that optometry has always worried a lot about. Ophthalmology, much less so historically. I will say, at least in the US now, that is beginning to change, and there is much more of a convergence, if I can use that term, between visual structure and visual function. Believe that they're interrelated in ophthalmology as well as in optometry. That was not true when I started out long ago. Most ophthalmologists believe that myopia was determined only through genetics. Environment played no role. They believe that correcting moderate degrees of hyperopia in a young child was unimportant because there's 15 diopters of accommodative reserve, so what difference does 3 diopters make? That's different today. Through the evidence basis that has been developing over the last 20 years, there's now a recognition by all eye doctors in the US, I think for the most part, that there is a strong correlation between refractive correction, function, between ocular structure and ocular function. Final point I'll make here is always consider binocular balance as a critical element in the correction of refractive error. I mentioned the issue of correcting an isometropia, and that's really what I'm talking about here. Unless you've got a good technique of being able to ensure that you are properly correcting the difference in spherical component between the two eyes, you need to pay a whole lot of attention to that, because if you don't do that properly, you can mess things up. You can break down binocularity, you can impair visual function, you can create an individual at a young age with amblyopia. You can actually create amblyopia if you mess this consideration up. More about that as we go along. All right, let's talk a little bit about very general concepts with hyperopia. In general, with young kids, you typically push plus with amblyopia or strabismus in young kids. You do not push plus in the absence of amblyopia or strabismus in young kids. Even more true with older kids or with adults. So you have to be very aware about the whole accommodative system and about latent and facultative hyperopia. You know, we all get that in our training. We tend to hear those things. We tend to hear those definitions. And then clinically, we tend to forget about all that. It's critically important to ensure that you don't push too much plus when it's not necessary. The only time you might do that in an older kid is if there's a really good reason, like there is a development of intermittent esotropia or high phoria in these individuals, and you might want to use that as part of your therapeutic treatment to push more plus. And obviously, you always need to be thinking about differences between distance and near nice way of saying you need to be thinking about the role of accommodation. With astigmatism in younger children, you give the full plus and the correct SIL, as I've talked about. You might be more conservative in older children who get a first correction. So if you don't see a 12-year-old, if you are, I should say, seeing a 12-year-old for the first examination, and it turns out they've got high SIL in both eyes, then I think it's completely reasonable to think about modifying that first rule. However, once you've got patients wearing comfortably astigmatic refractive corrections, make changes very conservatively and carefully. Think a lot about what you're doing. Any change can cause some functional problems and cause the patient to be quite unhappy with what you've done. Binocular balance. So I've already mentioned this. You got to really maintain that balance between both eyes. So let me pose a question to you. In a young child, a child where you cannot do a subjective binocular balance test, what we teach our NECO students, and perhaps it's different in Malaysia and India and other countries, we get them behind the phoropter or maybe a trial frame. This is, I say, a 12 or 15-year-old. We fog both eyes. We then disassociate both eyes, put prism up and down, base up in one eye, base down on the other eye. So simultaneously, the patient sees two images that are a little bit blurred. You ask the question, which is better, top or bottom? You modify the amount of plus or the amount of minus to try to equalize that amount of blur. You then take away the prisms. You reduce the amount of fogging, of blur, and you get best corrected visual acuity. That's fine when you have the luxury of cooperation from the child, when you have the luxury of being able to do a subjective examination. Remember, I talked about objective versus subjective before. How do you do it when all you have available is an objective evaluation? Well, the only recourse you have, in my estimation, is to do retinoscopy. And the way that I do retinoscopy to determine binocular balance is I provide a sweeping motion across both eyes. In other words, I'm going back and forth with my retinoscopic beam really fast across both eyes, and I'm equalizing that reflex. I'm providing a little plus or a little minus, whatever I need to, in order to get that simultaneously have equal amount of neutrality at the same point. I then double test myself by going back a little bit further, increasing my working distance, going forward, decreasing my working distance, and ensuring that I pick up neutrality at the same point, same distance from me to the patient in both eyes at the same time. In my estimation, there is no other way of being able to do that. This is a simple, rapid way of modifying the procedure of retinoscopy in order to provide binocular balance. Now, one of the final things I want to say on this point is I recognize the issue of cycloplegia versus non-cycloplegia. And in the US, as I said before, we cycloplege every single child on the first visit. We do a dry refraction and a wet refraction. I use both of those data points for me to determine what I'm going to prescribe, if at all. I don't use one or the other solely. I use them both, because in minimizing the accommodative response by cycloplegia, I get additional information. Now, one of the big studies that I've been involved in, big research studies, something called the Vision of Preschoolers study. It's a very large multi-center clinical study done across the United States in a number of centers. I was the principal investigator in the Boston site over the last 20 years. We looked at screening procedures, the best screening procedures possible in 3 to 5-year-old children, We compared a large number of potential screening techniques to a gold standard comprehensive eye examination done by experienced pediatric ophthalmologists and optometrists, all doing the exact same procedure in the exact same way. We found that the best screening procedure to detect the presence of amblyogenic risk factors, again, significant refractive error, amblyopia, strabismus, mediopacity, we found the best technique in the best hands, these pediatric experts, was to do dry retinoscopy, non-cycloplegic retinoscopy. We found that it had a sensitivity of 90% to be able to detect these important vision problems in a huge population of 3 to 5-year-old children. That's 90% accuracy of dry retinoscopy to pick up moderate to high hyperopia and or significant astigmatism. Now, 100 minus 90 is 10. That means that 10% of these children with significant, important amblyogenic risk factors were missed by retinoscopy by experts under ideal circumstances. Let me repeat that. 10% of kids were missed by experts doing dry retinoscopy. It's a nice way of saying dry retinoscopy is going to miss a certain percentage of kids, even in the best of hands. If people's hands are not the best of hands, if they're not experts, if they're less experienced or they don't really work with children or any other issues like that, that 90-10 split is going to change. It's going to be poorer in quality. You're going to miss more kids. So people who are not expert at doing retinoscopy are going to miss more kids. It means that everyone who examines eyes is going to miss children with even moderate to high degrees of hyperopia. I acknowledge that myself, with 45 years of experience, still consistently miss some children with 4 and 5 diopters of hyperopia. I do a dry refraction. I don't see what I should be seeing. Why is that? It may be my inability. It may be just that these kids are well masked. Now, nobody under any circumstances is going to be able to find these kids. So the bottom line is that without doing cycloplegia, you're going to miss kids. That's important, and that's something that is a rationale, in my estimation, for the necessity of doing cycloplegia. Again, I recognize that many of you are not in a position where you're able to do that. I understand that, but you need to kind of work as hard as you can to overcome that, both by being the best retinoscopist that you can be, as well as working to change the limitations on your scope of practice in your respective countries. Just going to touch briefly on myopia, and then we'll go to questions. Prescribing for myopia is easy. For the most part, you pretty much give whatever it is you find. Now, there are arguments to be made about undercorrecting myopia. For a long time, a lot of people who identify as being behavioral optometrists strongly believe that undercorrecting myopic correction slowed down myopia progression. Turns out, through many, many research studies that I'm sure you're aware of, turns out that's exactly the wrong approach. Turns out that the driving force behind myopia progression is optical blur projected on the retina. How do you get optical blur projected on the retina? By focusing an image in front of the retina. What is focusing the image in front of the retina called? It's called myopia. So if you correct a patient with myopia by still leaving them myopic, you are still maintaining optical blur projected on the retina. What we now understand is that that causes a series of biochemical events to occur first in the retina, then are somehow in some way transmitted to the sclera that provides a signal for axial elongation. Bottom line, maintaining optical blur, in other words, undercorrecting myopia, only exacerbates myopic progression. In other words, it's exactly the wrong approach. Now, that's a lot to take in because I'm sure many of you have heard that. You may have heard lectures on that, but that's not what the research shows. The research shows that's a bad approach. So typically, the best advice is give whatever correction there is. You could think about doing all the other things, myopia progression. On this slide here, again, I'm not going to get into this. This is a rapidly changing subject, and there's massive amounts of information that are coming out every day on this. Bottom line is that we still, bottom line, don't know how to eliminate myopic progression. We are beginning to understand a little bit about slowing down myopic correction, but for sure, we do not yet fully understand it. This is something that's going to play out in the future. So I think my 45 minutes are up at this point. I think this is a good time to stop. What I normally would do would now be to go through a large series of cases, specific situations, and how I would go about and how I would recommend you go about correcting those situations. But we'll need to leave that for another time and place. So I'll now turn this back over to our moderator, who will field some questions for me. So thank you.
Yeah, thank you, Prof, for your very insightful presentation and sharing your ideas about prescribing in children. So if there are any questions, can you post it on the chat box for the attendees? There was one question I think you have already answered, but let me just ask some of them. As for myopia control purposes, do you prescribe under correction or full correction?
Okay, so I think I did provide that answer. Bottom line, I will virtually never undercorrect myopia. And I don't think that the people who are now expert in this issue of myopia progression and techniques of myopia progression mitigation would argue that undercorrecting makes any sense. The only thing one might do that I guess maybe is a version of undercorrecting would be the use of progressive addition lenses, essentially providing bifocal add at near. I don't view that as undercorrection. I view that as reducing accommodative demand at near. I think that's a different story. So bottom line for me, I would never recommend underprescribing. And again, I know that that is something that's out there and has probably been taught for a long time. I don't believe that it's correct, though, and I think, again, the experts on myopia progression mitigation would argue strongly that that's a bad approach.
Yeah. There's another question. What is your opinion on prescribing single vision correction for myopes, given that there is so much going around in the world of myopia? I mean, is there single vision glasses your preference of correcting myopes? That's what I think the attendee is wanting to know.
Okay, so I was actually involved. I was one of the investigators in one of the first large-scale formalized studies looking at bifocal correction of myopia progression, the so-called COMET study in the US, the Correction of Myopia Evaluation Trial. And that was in many sites across the United States. I was involved in the Boston site. What we did is we arbitrarily provided progressive addition lenses to one arm of the group of young myopes who were already beginning to progress in their myopia. And we found in that study that providing, I think it was 2 diopters of progressive addition correction at near, that there was a statistically significant decrease in the myopia progression. However, we found that it was not clinically significant. In other words, the effect was small. It seemed to be greatest, almost oddly enough, in those young myopes that had esophoria, which was a little bit counterproductive, or a little bit counterintuitive, rather. But we found that that group actually did benefit somewhat more, and it was somewhat clinically significant in that group. There have been a number of subsequent studies that have been done that have pretty much shown the same thing. There is an effect. The effect is modest. In some individuals, the effect is greater, providing bifocal correction. And I would say from clinical practice, if you want to provide a simple technique that is not so invasive as ortho-K or some of the other contact lens uses that are being developed today, that might be a simple approach to it. I would not expect that there is, in most individuals, going to be a dramatic effect. There may be in some individuals, however. So I think what's safe to say is that there is some benefit in some individuals. There is less benefit in most individuals. And given the extra cost involved, it is something I think at least to consider for parents. There perhaps are better ways nowadays of trying to deal with the myopia progression issues through the use of drugs and the use of some of the aberration correcting contact lenses and spectacle lenses. So I think that there are a number of different approaches. My take, however, on all the sum total of everything that we're doing today about myopia progression is that we're only at the beginning of the process and understanding what's going on. I don't think that we have any highly effective techniques at this point. I think some things look better than others. I think maybe best of all is just keeping kids out in the sunlight for a period of time each day. That may be a simple and useful approach. But again, there's so much that we don't understand about all of this that I think anybody who suggests to any of you that you have now a solution to the problem is selling you something that is not accurate. I don't think we know the answer yet. We're learning more and more. In 5 or 10 years from now, we'll know a whole lot more. But it's like looking for the treatment for COVID-19. We don't have a treatment now. We don't have a treatment now for myopia progression. We have a lot of ideas, we have a lot of research, we have a lot of effort, and I do believe that at some point, we'll know a lot more than we do now.
Yeah. The other question is, can you elaborate more on taking care of binocularity in children? And will near retinoscopy some way help in making decisions of binocularity?
Okay, I'm not exactly sure of what that question was pertaining to. Maybe you could just specify.
Yeah, maybe we'll take it later. I think the attendee can rephrase the questions, but we'll take another one, Prof, first. You mentioned that undercorrection prescription might increase the progression of myopia. Technically, can we slightly undercorrect, or it's a no to undercorrect myopia?
Bottom line, no undercorrecting myopia whatsoever. That would be, for me, what I do, what I recommend based on the evidence basis. Now, maybe this is a good moment for me to say something about evidence basis, evidence-based medicine, evidence-based optometry. This, I think, is going to be one of the single biggest issues in the future that optometry has got to face around the world. A lot of what optometry has done in the past was not evidence-based. Some of the lectures that I heard previously, the last couple of days, had aspects included that are not evidence-based, that are anecdotal in my view. They are based on things that have been done by optometrists for a long period of time. But in my view, in the absence of hard and fast and formalized research, I think that that has been a huge problem for optometry as a profession in its 100-year history, that we have tended to not always been so evidence-based. Practitioners come up with techniques, they use those techniques on their patients, and based on a limited sampling, not in a formalized manner, people then talk about those techniques, they promote those techniques, they say that those techniques work because I've seen it in my patients. And I'm not discounting the value of clinical experience whatsoever. I acknowledge that clinical experience is incredibly important. But what I'm saying here is that we as a profession have got to do more and more embracing of the science. And to me, having participated in particular in the amblyopia treatment studies, I can tell you that many of the things that I was doing 30 years ago on a clinical basis were simply unsound. They were not techniques that we know today to be effective. In many ways, I was treating patients in ways that did not help them. And I have remorse about that. Nothing I can do about that. It's just based on my own personal ignorance of all those surroundings. It was just based on ignorance and the ignorance in me. But we have to have a scientific basis of what we do. The best example of that in treating amblyopia was the first thing I said before. The number one approach to treating amblyopia in children is provide refractive correction. Let me just say one thing about that. We now know from the ATS studies that somewhere on the order of 50% or more of children with amblyopia at a fairly young age, given proper refractive correction alone, are cured. Let me repeat that. You can cure up to 50% of individuals with amblyopia at a young age by simply giving refractive correction and doing nothing more. No patching, no penalization, no orthoptics, no vision therapy, no nothing else. Just putting refractive correction on them. We did not know that. It's the simplest approach to treatment for 3% of the population of children around the world. The biggest cause of significant decreased vision among more than half the population of the world is caused by amblyopia. Simply putting glasses on that population will cure half those people. There's almost nothing more that we can do in a public health context in terms of improving the quality of vision around the world than by providing proper refractive correction to the amblyopes. And as we know nowadays, through the work of the World Health Organization, and WCO, and everybody else, uncorrected refractive error accounts for maybe 80% of all cases of visual impairment around the world today. 80% is refractive error alone. So we didn't really understand that until fairly recently, but it has just been staring us in the face for 100 years, and we did not recognize that. That is why we need to have an evidence basis, and why throughout medicine, all fields of medicine, including optometry, the idea of evidence basis is enveloping everything. An unfortunate example in the wrong way today is with COVID-19 and my president Trump's idea about using chloroquine as a treatment, in spite of the fact that there is no research whatsoever to present that, is a perfect example of where evidence basis is critical. And the people surrounding him have pushed back on that and keep mentioning the necessity of evidence basis. And that today is the single most glaring example the world can see for itself. I'll stop there.
Yeah.
So actually, I see the online chat. I want to answer one question that I see here in front of me. And that is,
yes,
what is your opinion on performing Mohindra retinoscopy if cycloplegic refraction is not possible to prescribe for conformation or rely on the result of the dry retinoscopy done before? So the question is about the Mohindra technique. I can talk about that because Indra Mohindra was in fact my teacher in pediatrics at NECO when I was a student. And she was developing the Mohindra technique while I was at NECO, and I had some peripheral involvement in some of her work on that area. The Mohindra technique, for those who are unaware, is a technique of doing dry retinoscopy in a totally blackened room with no other light source, where the infant looks at the retinoscope being the only light source, and then you do a refraction based on that. You reduce the amount of correction you find by a certain amount, and that purports to find an accurate refractive error for the child. What I have to tell you is that one of my classmates, Mitch Scheinman of Scheinman and Wick, one of my classmates at NECO, who also had Indra Mohindra as a teacher, did a magnificent study many years later when he was at the Pennsylvania College of Optometry, where he is now, that actually refuted the Mohindra technique. It showed that it was simply not accurate. It had some value in some individuals, but its accuracy was not particularly good. I would say a better technique of retinoscopy on young children is to do, as I use the phrase, simultaneous retinoscopy. And what I mean by that is hold extra plus trial lenses in front of a child's eyes while doing retinoscopy of both eyes simultaneously. In other words, sweeping rapidly across both eyes while providing fogging to that child. You really can't control what the child is looking at, but you have some knowledge of what the child is looking at by looking at the pupil size as you're doing the retinoscopy. And as we know, if the accommodative system is relaxed, pupils are large. The accommodative system is being invoked, if it's being used, then the pupils are small. So you do your measurement in the instant when the pupils are large while you have plus in front of both eyes providing fogging. In my experience, that is a more accurate and more consistent way of doing retinoscopy of young children. So I'll stop there.
Yeah, there is one more pertaining to retinoscopy. There's one attendee who is asking if there is a difference between your dry and wet retinoscopy. Which one do you prefer, and is there any criteria of selecting the power?
Okay, that's a great question. And I mentioned earlier that, in fact, I do both on all children on the first visit. I always do dry retinoscopy, and then I always do wet retinoscopy. And then I make a determination of what I'm going to prescribe based upon both findings, along with everything else in my examination. So all the other aspects of my examination provide additional critical information. To me, refraction is not a standalone procedure. It is part of the entire process of examining a child or an adult for that matter. So I take both into account. If I see, for example, straight eyes and I think I'm seeing good vision in both eyes, I generally will not prescribe the full amount of cycloplegic correction. I'll almost never do that unless there is an accommodative esotropia present. I'll almost always dial back how much correction I'll give. And to a degree, it depends upon the difference between the two. So if there is a small difference between dry and wet, then I'll gravitate more towards the dry. If there is a big difference between dry and wet, if there's a 3 or 4 diopter hyperopic difference, then that tells me that there's a lot of underlying hyperopia that's present that the child is not manifesting under non-cycloplegic conditions. Under those circumstances, I may very well prescribe somewhat more than I would otherwise. So for me, the bottom line is, it's always a combination of all the factors that I have obtained during my examination. I will put all of them into my computer bank in my head and then make a determination based upon what I see and what my experience is. And I think we all do that in one way or another. Yeah. So we have our findings during the examination, we write down our numbers, but then in terms of what we actually do, it's based upon the sum total of all those findings and our experience and what we've learned and hopefully on some evidence basis as well. So bottom line to answer that question is, generally it's somewhere in between dry and wet, closer to wet in the case of accommodative esotropia, somewhat closer to dry in the absence of that.
Okay, thank you very much, Prof. Do you want to take one last question from the attendee who has rephrased the question? So she rephrased it to, how do we take care of binocularity in cases where we do not have the luxury of the response from the child?
How do we deal with the binocularity issues when we don't have subjective results? Is that the question?
Yeah, yes, when we don't have any response from the child. Is there any specific technique
then
or
you're
tips?
going back to your, so you're going back to your objective examination again, the sum total of that. So if the child is too young, or maybe a special needs child that's incapable of providing good subjective answers, you may not be able to get visual acuity results. And if you're not able to get good visual acuity results, you're not going to be able to get good stereo results. So what you're left with is what you see. If you don't have the numbers attached to stereo and you don't have the numbers attached to acuity, then you're left with what you see on a behavioral context. And, you know, I think the answer to that is, how do I say this? It's complicated. It's not simple. You have to go by what you're seeing in the child's behavior. And I think another point that I haven't touched on is that if on this first examination, and this was mentioned in the other two lectures that I listened to from the series, if you can't get all the information on the first visit, then you need a second visit to try to get a better understanding. So I would leave that as part of it. But in terms of binocularity, I think what you're left with is you don't have much. You can't necessarily do a good stereo test. You probably can't do something like Worth 4 dot. So what you're left with is, if the eyes look straight, you do a cover test and they still look straight. But if you see an isometropia, then if I see an isometropia and I see eyes that on a cover test look straight to me, then I'm pretty sure that what I'm going to find is a microtropia. So what I then do, and I do this with every individual, every child that has any anisometropia by my refraction at all, I do a 4 base out test. And this was also mentioned in one of the lectures the other day. 4 base out test is an incredibly underappreciated procedure. And it may be the only objective binocularity test other than cover test that you can really do. Now, just to review really quickly what the 4 base out test is for those who are not familiar with it. Anytime I have an isometropia, I believe I'm going to find a microtropia. And what I do is I take a 4 base out handheld prism, I put it in front of what I think is the good eye. Put the 4 base out prism in front of the good eye. I look at the response of the other eye, the fellow eye, and what I expect to see is that eye moving out first, and then having a refixation movement inward. So prism goes in front of the good eye, the other eye, the fellow eye, turns out, then turns back in. That's a normal response. What that indicates is that that 4 base out prism changed the location of the image on that good eye. It took it off the fovea, it put it on an extra foveal point. The eye engages in a vergence movement to pick up fixation, so it realigns the macula with the new position of the image. And in doing so, as a result of Herring's law of equal innervation, the fellow eye engages in a conjugate vergence movement out and then a refixation movement in. That's the normal response. You put the 4 base out prism in front of the other eye, and what you get is no movement at all on the fellow eye. Fellow eye in this case being the good eye. So you put the 4 base out prism in front of the bad eye. Because there is a suppression scotoma, there is a functional blind spot surrounding the surrounding the fovea of that eye. When you change the position of the image on the retina of the bad eye, that eye does not recognize that the position of the image has changed because there is that suppression scotoma. As a result, there is no outward movement of the good eye and then no inner movement of the good eye. In other words, you put the prism in front of the bad eye, there's no movement of the good eye. That to me tells me that there is an impairment of the binocular function of that child. Now, again, the cover test gives me an indication of a grosser version of that, but the fine version of that under 4 diopters, by definition, is the lack of a proper normal response on the 4 base out test. So that's what I do. Now, that doesn't make me change what I'm going to do. What I'm still going to do is provide the refractive correction in front of both eyes. And if I see a +6 in front of the bad eye and a +2 in front of the good eye, then I'm going to give probably a 4 on the bad eye and a plano on the good eye, with some combination like that. I'm going to maintain that 4 diopter difference. I'm going to leave those glasses on for a period of a few weeks. I'm going to have a child come back. I'm going to redo my testing, including the 4 base out. And I will leave those glasses on in that way without doing anything else, even if I can't get a visual acuity response, a quantitative, I should say, visual acuity response, to know what the actual numbers are. I will continue to do that until I no longer believe I'm getting improvement in visual acuity. On a child old enough, then of course I'll monitor the visual acuity, and I'll continue glasses alone until there's no longer any further improvement. If I don't get to normal on the bad eye, then I'll start patching or atropine or whatever else. Now, the last thing I want to say about that, and this has to do also with the talk about amblyopia the other day. The lecturer touched on a lot of the new concepts that are being developed about treating amblyopia. And what he sort of said but didn't say out loud is something that I will say out loud. For those of you who are young in the audience, 10 or 20 years from now, you are no longer going to be doing patching or atropine penalization at all. You are all going to be shifting to a completely binocular approach to the treatment of amblyopia. There are a myriad of techniques that are being developed around the world today that employ binocular stimulation of both eyes at the same time to break down the amblyopia, to break down the suppression, to improve the binocularity. The initial results have been highly variable in many of these techniques. There have been some successes, some failures. I've been involved myself in some of these. What I could tell you is that this is where all the action is now, and this is where all the action is going to be in the future, and this is the way that people are going to be treated in the future, is through a whole lot of different binocular techniques. So an answer to the question that was posed to me initially is, how about binocular function? It's going to be a whole different story 5 or 10 years from now than it is today. We're going to have an understanding about the mechanisms, the underlying neurology of amblyopia that are going to transcend everything we clinically do today. I'll stop there.
Yeah, thank you very much for your explanation, Prof. Before I introduce to the next speaker, I would like to thank Prof again for taking out the time and accepting our invitation to be the speaker and sharing your ideas. Thank you very much from the team OOLS. And we would definitely like to hear from you in the nearby future again, Prof.
I'd be very happy to give additional talks about a variety of topics. Thank you very much.
I will get in touch with you for that, surely. So tomorrow, yeah, a lot of questions were there on myopia management. So we have a very young optometrist. She's been into myopia research for quite some time now, and she will brief us about her opinion on myopia management. So wait for it and tune in tomorrow. 11 a.m. India time and 1:30 Malaysia time. Until then, stay safe, stay home, and good day, everyone.